Thank you for joining us for today's webinar. My name is Margo Williams, and I'm a Senior Associate of Practice Management at the American College of Physicians. At ACP, I work with our members, most of whom are in small to medium-sized practices, on a wide variety of medical practice issues, including practice management, coding and reimbursement, informatics, regulatory compliance, and care delivery models such as the PCMH. I'm here today representing the Care Delivery and Integration Center at the PCPCC. Today's webinar will highlight how two very different primary care practices approach their transformation to a patient-centered medical home and employed new strategies to improve outcomes for their patients, especially those with diabetes. These practices are among the 52 practices in the Maryland Multi-payer PCMH Pilot, which Discern Health administers for the Maryland Health Care Commission. Before I introduce today's speakers, I'd like to go over a few announcements and housekeeping items. I'm not sure what I'm repeating, but I'll give it all again just in case. The PCPCC Fall Annual Conference is less than a month away. The conference will run from November 12th through 14th at the Grand Hyatt in Washington, D.C. Make sure you register soon because online registration ends on November 4th. Also this year, the PCPCC is hosting its first awards dinner during the conference to honor leaders in the field of patient-centered primary care. You can find more details and register for the conference at pcpcc.org/events. PCPCC's October National Briefing is next Thursday, October 30th at 1 p.m. Eastern. During the briefing, Lisa Dulski-Watkins will join the PCPCC to discuss her latest Milbank Memorial Fund report, Aligning Payers and Practices to Transform Primary Care, a report from the Multi-State Collaborative. You can register for that event on the PCPCC website. Now for some general housekeeping regarding today's webinar. Please use the webinar software to ask questions or provide comments. To do this, submit your questions in writing using the drop-down question box on the right side of your screen. During the last few minutes after our hosts have finished presenting, I will open up the Q&A from the audience. Also, please note that the slides and the recorded presentation will be posted to the PCPCC's website within the next 24 hours. Now it is with great pleasure that I introduce today's participants. Linda Shelton is a partner with Discern Health. She has over 30 years of experience developing programs focused on innovations in healthcare. She's focused particularly on the patient-centered medical home since 2001. At Discern Health, Linda leads client projects related to quality measurement in the medical home and participates in the overall management of the firm. Her current projects include the Georgia Academy of Family Physicians PCMH University, the Maryland Multi-payer PCMH Pilot, the analysis of IT vendor products for PCMH support, and a case study of how PCMH's perform well on diabetes outcomes. Prior to joining Discern, Linda operated her own consulting enterprise advising clients on quality improvement initiatives and healthcare management strategies. She has a 20-year association with the National Committee for Quality Assurance as both an executive and a consultant. At NCQA, she led the development of or has been heavily involved in several NCQA physician measurement programs, including, among other things, NCQA's Diabetes and Heart Stroke Recognition Programs, Bridges to Excellence, and the Integrated Healthcare Association's Pay-for-Performance Program in California. Linda has a master's degree in healthcare administration from George Washington University and a bachelor's degree from Tufts University. She's served as a speaker and a task force participant for many national organizations, including eHealth Initiative, the National Business Coalition on Health, the Care Continuum Alliance, and the Health IT Summit. Beth Little-Terry is the Chief Executive Officer at Mountain Laurel Medical Center, an FQHC in Western Maryland. Beth has nearly 30 years of experience in various aspects of the healthcare industry, including mental health and substance abuse, Medicaid administration, managed care, healthcare financial systems, operations, and executive management. She joined Mountain Laurel as the Chief Operating Officer and became CEO in November 2007. In her capacity as CEO, Beth directs all aspects of federal grants management, ensures organizational compliance with all program expectations and reporting requirements, facilitates the achievement of the health center's mission as set forth by the Board of Directors, oversees Mountain Laurel's financial, operational, and clinical performance, and leads the health center's strategic planning efforts. Prior to joining Mountain Laurel, she served as the Chief Operating Officer for Sunshine Community Health Center in Talkeetna, Alaska. Prior to moving to Alaska, she directed a state of Florida Medicaid managed care program in 8-county region with the Agency for Healthcare Administration. Kim Johnston is a physician and owner of Johnston Family Medicine, where she has been since 2000. Johnston Family Medicine is located in Westminster, Maryland. She also serves as the medical director at the Carroll Physician Hospital Organization in Maryland. She received her bachelor's degree at Western Maryland College and later attended the University of Maryland Medical School. She completed her internship and residency at the University of Maryland Medical System in Baltimore. Now it's time for our special presentation, Patient-Centered Best Practices. Linda will kick off the presentation and ask Beth and Kim questions about how they approached practice transformation and improved clinical outcomes, especially for their diabetic patients. Now let's get started. Take it away, Linda.
Terrific. Well, I'm here with Dr. Kim Johnston, and Beth Terry is also on the call. We at Discern Health have had the opportunity to work with the Maryland Multi-payer PCMH Pilot, which was led by the Maryland Healthcare Commission. And as a result of doing that, we have tracked quality measures for 52 practices in Maryland. And it was using the data from our practices that was the genesis of this project. And now, Carolyn, would you advance the slides? So here is the here are the reports we produced as a part of that project. The one on the left is an in-depth report on our case studies. The one on the right is a somewhat shortened guide to what we learned and how to put it into practice in your practice. And we're going to talk with leaders of 2 of the 5 practices that we developed case studies on in this project. Next slide, please. What was unique about it was we started with outcomes because we had clinical quality outcome measures, basically meaningful use measures specified by the Maryland Healthcare Commission for all of the 52 practices to report. So we were able to analyze our data and pick practices that were at least the 90th percentile across all 52 practices. We also diversified, looked a little more broadly at things like practice location and patient type. And then we went to each practice and held in-depth interviews with staff at all levels of the practice to get their input and their thoughts about how they produce good outcomes, especially for diabetes patients. We found that each practice had a unique culture and self-identity that was very interesting and sometimes, was volunteered and didn't come even as a result of our interview questions. And then when we scored our interviews and analyzed them, we found that there were 6 similar techniques that all of the practices employed. They did them in different and interesting ways, which we'll talk with Beth and Kim about, but they all focused on very similar areas. I'd like to ask Catherine Kucharski of Sanofi US to comment a little bit on the genesis of this project, and then we'll go into a little more detail.
So, thank you, Linda. So the genesis of this came that as part of the Sanofi Medical Affairs Department and Evidence-Based Medicine Group, we're very, very interested and also committed to identifying and understanding the evolving landscape of diabetes management beyond just what the medications that are being used within that. And we were very, very interested in how this looks specifically within the context of a patient-centered medical home model of care. So the conversation started with the Maryland Healthcare Commission just around broader population health types of topics, but this whole concept of what is this secret sauce really emerged as a very common interest and gap of information. So we dialogued around how could we pursue this in a very organized and objective fashion, which is then when the Maryland Healthcare Commission wrapped in Linda and the Discern group. So from there, we developed the interview questionnaire. The interviews took place. So I'm thrilled that this collaboration has resulted in some very key insights and information that are going to be shared by Discern, are going to be utilized by Sanofi, and now today through the PCPCC. So thanks for that opportunity to give a little bit of background. So I'll turn it back over to you, Linda.
Okay, thank you, Catherine. Could we have the next slide? So these were our criteria for selecting 5 practices to focus on. Primarily, we focused, as I said, on diabetes clinical outcomes, but also looked at diabetes-related measures, which were in the measure set that was reported. And then secondarily, we looked at practices' NCQA levels because they all had to have NCQA recognition as part of qualifying for the Maryland Multi-payer project. We wanted a range of sizes. We wanted both small independent practices and large group practices that were associated with health systems. And we looked at geography and urban and rural. And so came up with 5 practices that gave us enough diversity in representing the state and that all had excellent outcomes. Next slide, please. So here are the measures. The core measures are diabetes outcome measures that are in meaningful use. And then we also looked at the related measures, LDL levels, tobacco intervention, and weight screening and follow-up. Ranked the practices for each measure and then calculated to obtain an overall rank and picked the top 5. Next slide, please. So I mentioned that there are 6 techniques that were common to all 5 practices. These first 2 are particularly strong and particularly interesting because the first one is about really diligently following up to make sure that diabetic patients get the tests they need, get seen when they need to get seen, have a constant partner in the practice that helps them manage their condition. And I have some contrast there with the NCQA requirements. I think in every case, the practices that we interviewed go well beyond what NCQA requires in these areas. And so the second area is customizing plans for the patient. And we heard a lot of really interesting stories about suggesting that patients will walk up and down all the aisles at Walmart, suggesting that they park far away, basically working with individuals to set goals with individuals and based on individuals' interest in changing. So it's both the population follow-up and the creative initiatives with individuals. Number 3 was an identified care management function, something actually required by the multi-payer program. Interesting in that each practice assigned this in a different way. Different levels of staff carried this out. They had different functions, but they were all integrated with the clinicians in the practice, and all identified care management as an essential function. Next slide. They were all really good at using their IT system. Not only have decision support, but use decision support. As well as using their systems to measure what they do. They all took the comprehensiveness principle of patient-centered care very seriously. They all talked about how they work with the whole person, treat behavioral health issues as well as physical issues. They all are challenged, as we find practices are everywhere, to obtain behavioral health services for their patients. And so these practices saw that as their role and treated patients very comprehensively. They also really managed relationships with subspecialists. And then there was, in the background, as part of the way that they worked, there was excellent leadership, very impressive teamwork in the way that they talked to and about each other. Clearly a commitment to each other as well as to their patients. And then very good ongoing methods of communication, whether through meetings or messaging or face-to-face as individuals. Next slide, please. So this shows where the two practices are that we'll hear from today. Mountain Laurel is way out in snowy Oakland, Maryland, in the mountains. Johnston Family Medicine is in Westminster, which you might call an exurb or a fairly far out suburb of either Baltimore or Washington. Lovely area. Next slide, please. Mountain Laurel is a federally qualified health center. Next slide. Here's a picture, and the next slide gives some basic facts about Mountain Laurel. They do have a very diverse patient base. They take all patients regardless of ability to pay. Governed by a community board, a nonprofit organization, and a federally qualified health center. Next slide. Okay. Key thing here, the top bullet, there are 3 family physicians, 2 nurse practitioners, and 3 PAs. And they have been very diligent about qualifying for NCQA patient-centered medical home recognition and have seen the patient-centered model of care as part of their identity. And I would say that the same is true of Johnston Family Medicine. Next slide, please. This is Johnston's cover page on their website. And you can see in the bullets there, the first thing offered is a virtual office visit. So they're into today's patient-centered technique. And this is a practice of 1 physician and 5 nurse practitioners and physician assistants. Next slide. Okay, these are our 2 speakers, Beth Littleterry, the CEO of Mountain Laurel Medical Center, and Kim Johnston, the physician and owner of Johnston Family Medicine. So I'm going to start us off with some questions. First of all, we talked about culture and self-identity and brand. Beth, what do you think is the brand of Mountain Laurel Medical Center? What are the few word phrases that you might use to describe your practice?
Sure, and it's a phrase that's frequently used, and we refer to it as our culture of caring. And it's more than just, caring for the patients. That includes the staff and each other, because we believe that you have to create an environment internally that patients can feel also when they come in to our center. And so it's pretty simple and straightforward, that culture of caring.
Mm-hmm. Great. We now actually, as a result of having done this study, when we work with practices to help them transform to patient-centered medical homes, one of the first things we do is ask them to decide what their brand is and sort of see how that develops throughout their development. Kim, what's your brand?
I don't know that we've ever really thought about it as a brand, but what we do is take care of families. We think of each other as our family, and I feel that our patients feel that and feel that we treat them that way. So one word would, I guess, be family.
Great. Thank you. So getting back to those 6 techniques and starting with that really basic, what football fans would say, blocking and tackling, of keeping patients in your site, particularly patients with chronic diseases like diabetes. What's your technique, Kim, for doing that? How do you make sure they get back in?
One of the #1 things we do is make a decision individual by individual patient, but we control appointments based on refills. Our medical assistant staff who has the refill protocols knows that if a patient is out of medicine, that means that they're due for an appointment, that we want to see them. And that's a #1 cue to bring somebody in.
Mm-hmm. So you actually monitor whether they're out of meds, or do they call you to say they're out?
It's when they call.
Okay.
Secondarily is we have a population management report that we get quarterly that shows those patients that fall through the cracks that just haven't had blood work in a timely fashion.
Okay, and you reach out to them proactively. Beth, could you talk about your method?
Sure. There's a number of things. Certainly the daily huddles help us to focus and identify on all of those patients, and that no one leaves without an appointment, and with a connection with a person that's part of their care team. And so, we do, the things that many folks do as well in terms of reminding people and calling for their appointments. But most of the people, particularly our diabetic patients, are already currently working with our nurse care coordinator, and so there's a great link, and because of that, they want to come back. So it's not difficult for us to get them to come back. The other thing that we're doing, and we'll go live at toward the end of November, we have purchased and will be implementing a population management tool that will lay on top of our existing electronic health record. That will make it much easier for us to be able to pull data at any point in time, and to be able to identify those patients and continue to always do the outreach and utilize that information as part of our daily huddles.
Mm-hmm. Good, thanks. Beth, staying with you, one of the things we always try to encourage practices to do with chronic disease patients is get lab work done ahead of a visit, so that the visit can be most meaningful. And I remember you had reasons for not doing that. Do you want to talk a little bit about how you handle?
Well, we certainly do encourage everyone to do that ahead of time, but there's some physical barriers. I mean, sometimes just the the travel and the lack of transportation and the challenge to get there to have 2 visits or in a month is difficult for many of our patients. And so we encourage, but there are sometimes it's just not possible. And so we end up having to do the lab work on the same day that they're there, which still requires us the following day because our lab results are populated back into our electronic health record the following day. And so our nurses are very proactive in working within the teams, identifying what we need to do, and alerting the providers in case we need to change a method of treatment or how we may have interacted with a patient just the day before based on that. But our goal really is still to try to ensure that we're able to bring our patients in ahead of time, and that connection again with the care manager is critical.
Thank you. Kim, would you comment on that about getting lab work done ahead of time? I think your practice was different in this respect, in that you do it almost always.
We work very hard to have labs available at the time of our visit. Patient population is likely much closer to our office, so getting in a week ahead of time or a few days ahead of time isn't as troublesome for them. And that starts from the front desk when they make the appointment all the way through to our back office, where they know the protocols of the patients coming in. They're starting to tell them from the time they're asking to make an appointment to schedule also that lab visit so that the labs are available. If there's not already an order in the record, they're sending a message to the provider to put an order in the record so that the order is there when the patient shows up for their lab draw.
Great. Staying with you, we heard a lot of interesting stories in this during these case studies of particular styles of working with individual patients and examples of engaging an individual and helping them to get motivated in managing their health. And I wonder if you'd share one from among your patients. So I'll just sort of comment also that what we heard from most of our practices, what was really a description of motivational interviewing. I mean, we really, without the practices using that term, they talked about getting to know the patient and figuring out what's important to the patient and keying their diabetes goals on what's important to them and what they're willing to do.
Oh, yeah, absolutely. I mean, we have patients who, when they first come in, are having difficulty walking to the kitchen. So, you can't ask that patient to walk for 30 minutes 4 times a week as their exercise. So you start off by small baby steps, with let's get up during a commercial and walk to the kitchen and back, or every other commercial, or it really depends on what their lifestyle is and what they're already doing and what their capacity is. And it takes that extra 5 minutes of finding out where they're at, rather than just giving them the blanket standard prescription for exercise.
Right. Thank you. Beth, do you have an example for us of tailoring goals, especially for diabetics?
Sure. I actually have 2 that I'd like to share. One of the things that we have learned in our process, we had to, our nurse care manager, we had 2 different nurse care managers, and so I share that simply because personality certainly has a tremendous amount to do with engaging that patient. So with that said, one of the things that our care manager does with our folks is she will have a long list of vegetables and non-starchy vegetables, and to see, to talk with the patients about what they like, because it's irrelevant whether they're not going to do anything if you provide them or help them with developing a diet based on things that they don't even like, whether it's healthy for them or not. And so that helps then the care manager and the patient to really tailor and develop their whole meal plan design, based on the things that they will eat. And so she provides them with lots of choices and information. The other thing, is really about she has the patients describe their environment to them, to her. For example, how far is it to your mailbox? Does your driveway even have a hill or anything? And do you have a garden? And so that way, too, they can really tailor and develop an exercise or a fitness kind of goal, just being in their own environment. And that seems to work very well for the patients and for Emily, helping them to tailor their own plan.
Mm-hmm. And how big a caseload does she carry, the care manager, and how do you decide who stays with her and who maybe just sees regular providers?
Well, it's hard to say at any given day, and it can be. She's got several hundred patients actually that she's working with, and clearly, some are much more needier than others, and the work that she does with the providers, it's not an either or, they see them or they see her. It really truly is a collaborative effort, and working with the providers in particular, especially when she has a newly diagnosed patient, the provider may just walk the patient down the hall, and so she has to, try to make the patient comfortable and go, here's what we can do together to help you. And so she has a bit of a challenge sometimes with balancing the volume of the patients. And then throughout the huddles and the discussions with the providers, they were able to determine how well a person's doing, and gee, they may not need that much assistance or direction or help or guidance. And so that's kind of the determining factor for, how many people she actually follows at any given time.
Mm-hmm. Okay, thank you. Kim, do you want to comment on care management within your practice? It seems like there was a lot more sort of attention to the database and monitoring where patients are and reaching out to them.
We started off with actually moving a very seasoned, experienced medical assistant into more of a care manager role, and she follows and works hand in hand with the providers, also working with the identified patients that have those high chronic needs, as well as our discharges and hospital admissions and ER visits. But we also do rely a tremendous amount on data that we receive from a research network that we are part of.
Right.
And we work that data very quickly as it comes in on a quarterly basis, which pulls a lot of who's had hemoglobin A1Cs, who's out of control, who hasn't had a blood pressure reading, medicines that are interacting. We get that kind of data, and we're able to get reports that actually have patients' names, patients' phone numbers, and our care manager works with that data to get people in and get issues addressed.
Great. So that sort of is parallel to the registry function that Beth talks about. That
Correct.
sits on top of her EMR. Yours is through your research network. Great. So I want to talk a little bit about developing as a patient-centered medical home, and what was really hard, what was just a continued extension of what you were already doing. how did that development go for you, and what kind of help did you need or get? I'm looking at Kim now.
We actually found when we started to get into the details of the medical home that we were doing a lot of the basic concepts, but just not in a very organized fashion. We certainly didn't have a care manager identified. So that was probably one of the first steps, is actually pulling that role out and separating and learning to truly have that function and use it appropriately as an intermediary between the providers and the patients, allowing the providers to work to their highest level, and at the same time allowing our support staff to work to their highest level. That was definitely one of the things that we found we had not been doing nearly as efficiently as we could have been doing. So the transformation process was, I think, happening just by virtue of I feel, what we do in family practice. One of the most difficult things that we had was actually the documentation that the certification required.
Okay.
So that was where we had the majority of our support and our help was through that process.
I see. Beth, can you comment on your development as a patient-centered medical home?
Sure. It actually was. It was fairly simple, just because our culture was already in place, that we were very patient-centered and very patient-focused. And so, you know, we had some challenges with kind of harnessing the things that we needed to do to, you know, really demonstrate transformation. But it was, and I would echo very much what Dr. Johnston said, it was already kind of there. It's what we do in family medicine and what our providers, you know how to do. And so it really was a matter of harnessing, and it gave us an opportunity to continue to showcase what we're doing, and then to continue to build upon the core of you know, the foundation of our practice as well, that, you know, we already were patient-focused and patient-centered. And so just being able to, you know, like I said, pull those things together to go, this is how we're transforming, and this is what it looks like, and being able to demonstrate that, because, you know, submitting the documentation it was, as Dr. Johnston said, was a bit of a challenge too initially.
Right. Both of your practices have community-oriented sort of adjacent functions or businesses. In Dr. Johnston's case, a wellness center. In Mountain Laurel's case, a lot of community-oriented activities, including cooking classes. So, Kim, I wonder if you could comment on how you see the interaction developing between the wellness center and your care for patients with chronic conditions.
The introduction of the wellness center to the practice almost 6 years ago just was, I believe, was part of the change in the way we looked at a patient, and looking at the patient as a whole, and not just the individual encounter and what was wrong that day, but how overall globally, you know, we could make them feel better. As we started to look, the Wellness Center was born out of the process of beginning to practice bariatric medicine, but we also look at now hormone replacement and other wellness techniques, and it melds very well with the patient-centered focus.
Great. Beth, would you comment on your sort of adjacent activities within the community?
Sure. We have worked on establishing a partnership with the Maryland Food Bank, and we're a delivery site for once a month that over the summer, and we have particularly fresh foods that are delivered that we are handing out to our patients and anyone else in the community as well. But in addition to that, our nurse care manager has developed and identified certain patients that are very interested in learning how to cook utilizing fresh foods and whatever. And so in our kitchen, we have once a month, and we'll be holding one here in the next few weeks, a cooking class that's really focused on not just eating healthy and eating the right foods, but also what can you afford to do, because sometimes that's a huge barrier for many folks that have difficulties perhaps eating the proper foods, or grocery shopping within their budget that's going to help and with their health care condition. And so those things are pretty important to us. The other thing that we're doing within the community, and many of our diabetic patients, as probably most often have other conditions as well, including hypertension and even cardiac disease. And so we have a partnership that we have forged with a local dentist who has agreed to do periodontal screening for this group of patients because he's very interested in being able to identify oral health concerns that would impact their outcomes with their diabetes and their heart disease and those kinds of things. So once he does the screening, we're also able to assist our patients that have identified problems and need additional dental work. And so that's been a great partnership, and it's been an affordable endeavor for the patients as well, based on the financial arrangement that we have also with the private dentist.
Okay, thank you. So that I don't monopolize our two speakers, I will ask Margo if any questions have come through from participants that she'd like to ask.
Yes, we have several questions that have come in, and some of them are kind of groupable. So I'm going to start with the question that a couple of questions have asked about what software, either EHR or population management, are you using, and how do you use it to manage and stratify the different different chronic diseases?
Okay.
Okay, this is Beth. We are currently using NextGen as our electronic health record system, and like many, there were a few challenges trying to extract the data that we needed, and so we also purchased a product called Eye2Eye, and that hasn't been deployed yet. That'll happen at the end of November, and that's the tool that will be able to help us to stratify and to be able to really focus in on areas that we know that we want to target.
Okay, thanks. Kim? We use McKesson Practice Partner as our EMR, and the population tool that we actually have used since late 2000, so almost 14 years now, is the collaborative agreement that we have with a research network that is based out of the University of South Carolina's Family Practice Department, called PPRNet, and they actually mine our data, and so we are very, very lucky, and don't have to have a tool in place locally. Right. Right. We have found actually that PPRNet is a source of benchmarks for a lot of practice level measures, where benchmarks are hard to find. Excuse me. Any other questions, Margo?
Yes, we have several questions regarding other members of the team besides the physician, nurse practitioner, MAs, and so forth, such as endocrinologist, women's health, behavioral health, nutritionist, pharmacy, cardio. How do you incorporate them into the care, and how do you set up the arrangements?
Okay, Beth, why don't you start with that one?
Okay. Well, as you know, we're in Western Maryland, and it's a small rural community, and so there's, quite honestly, very limited resources in terms of access to specialty care, and there's limited service to us internally as well. And so our providers end up having to manage much of the patient's needs and care on their own. But however, they are very heavily incorporated, those that we access from a distance, into the treatment teams. Our treatment team also incorporates and includes our patient schedulers and our referral staff that are helping to manage and provide that information also back to the providers in terms of the team discussion on the patient care.
Okay, thanks, Kim. And we don't have any of those services in-house. However, my local hospital, Carroll Hospital Center, has done a tremendous job in their own efforts with population health, and so through their efforts, we do have the opportunity to have referrals to the diabetic education centers, the nutritionists, right in our own community. So that's all through referral at this point. Thank you. Any more questions, Margo?
We have more questions than we're going to be able to get to. The next question would be, kind of the grouping that I can see would be related to some of these patient involvement. How have you involved the patients and the family caregivers in improving your processes and the transformation of how you involve patients? Have you ever included patients in the discussion group or Q&A? In other words, do you ever get the opinion of the patients? I think that kind of sums up the questions regarding the patients.
Okay. So I'm assuming that question is about talking with patients outside of the exam room, so actually consulting them on the practices plan.
Yeah, like patient engagement type thing.
Right.
Yeah.
Okay. Okay. Beth, would you like to start on that one?
Sure. That happens frequently, actually, with engaging the family members, particularly if you're really trying to help a patient to change their eating habits and how they're doing and what they're eating, especially if, for example, it's a person that loves their spouse's cooking, and so that we've got to engage that family, and we bring them in to talk together as a family, and learn ways and talk about ways to alter some of the things, some of the processes and the ways that they do things within their home. So it happens pretty frequently for us, actually, that the families are engaged in that process.
Okay, great. Kim? I have to echo that. You have to identify who the patient support system is, and obviously with their consent, but then engage the people as well. Good. Thanks. Margo?
I think we're about out of time, but I have one more question, and that is, how has making the transformation to a patient-centered medical home and improving diabetes affected other areas of your practice, such as financial viability and employee retention?
That's a good question. I'll let Kim start on that one. Obviously, the increasing the awareness of who needs to be seen and bringing people in drives your patient visits up, which increases your revenue, and that is a good for patient practice viability. As far as staff retention, the feeling that they're part of the team, feeling that they make a difference, being able to see the results of their efforts in actual data when we get the reports, and they can see when we're working on a certain aspect, and they can see how
the data point moved from one point to the next point, gives them a sense of ownership, which overall I believe it makes people feel more job satisfaction, which certainly aids in retention.
Right. The other thing I would mention that the Maryland Multi-payer project does calculate savings from the different practices looking at total cost per patient, and provides the opportunity for these patient-centered medical homes to demonstrate that they hold down total costs and thereby share in the savings to the system.
Sure, and if I can add just a couple of things to what Dr. Johnston said, but I also want to go back to that previous question very briefly because there was something that I had neglected to share. In terms of patient engagement, we frequently, 2 to 3 times a year, we're conducting patient satisfaction surveys and various types of assessments because it's very important that we're getting their feedback and really understanding. And we'll do very focused surveys as well on a specific population to try to get to, what they think are, concerns and things that we can do and we need to do differently. The other thing that we did very recently in terms of having patient input and involvement, we created a little group called Friends of Mountain Laurel, and that really is a consumer-driven group so that it provides them the forum to say, hey, this is what I would like to see, or this is how I think, this is what we need, or this is what my neighbor needs in terms of, care and help and service. And so I just wanted to be sure I covered those 2 important things. But as far as, you're absolutely right, with being having the financial incentive, if you will, through the pilot project, it certainly does help in sustaining us financially, but we've always believed it's just the right thing to do anyway, regardless. And so, our staff get extreme satisfaction, quite honestly, of even just that one patient story at a time of someone's success. And so our employee retention, we do pretty well because, again, it's that established culture of caring about our patients and really, making sure that they're connected to us, and that we're connected to them, and we understand what their challenges are to be able to help them to manage their own well-being. And so it's like I said, it's just kind of the right thing to do regardless.
All right. Well, thank you. I think we've run out of time today. I'd like to thank our wonderful speakers, and thanks to everyone for participating in today's webinar. Again, we hope you can join PCPCC's upcoming national briefing on October 30th to hear Linda Dulski-Watkins discuss her latest Milbank Memorial Fund report, Aligning Payers and Practices to Transform Primary Care, a report from the Multi-State Collaborative. You can register for that event at PCPCC's website. And one more time, the slides and recorded presentation from today will be posted on the PCPCC website probably by tomorrow. So thank you, and have a great rest of your day.
Thank you.
Thank you.